So again, welcome to Samaritans Perth International Health Forum. Today we are very fortunate to have Dr. Burton Lee. Dr. Lee has been affiliated with African Inland Mission since 2010, both teaching and caring for patients in the intensive care unit at Kajabi Medical Center in Kenya. Dr. Lee completed his BA at the University of California, Los Angeles, and he subsequently received his medical degree at Harvard Medical School, where he eventually completed his training to become a pulmonologist and critical care specialist at Mass General Hospital. Prior to his work in Kenya, he was a former director of the Washington Hospital Center Pulmonary Critical Care and Emergency Medicine Critical Care Fellowship Programs, and is currently an associate professor of medicine at Georgetown University School of Medicine. So we are delighted, Dr. Lee, to have you today to speak about evidence-based care of patients with severe sepsis. So thank you so much.
Well, thank you very much for the invitation. What I hope to go over are just some of the basic concepts for care of patients with severe sepsis, make some commentaries about care of sepsis patients in limited resource settings, as well as get into some of the recent literature that may be modifying some of our thoughts about how to care for these patients. So maybe I can go to the first slide with content here. So these are our goals. One is to review the definition of the various terminologies that people need to be familiar with. Second is to review the current international guidelines for management of patients. And then number three, to discuss some of the recent trials that have modified maybe our thoughts about the international guidelines that's been previously adopted. And assuming there's time, maybe we can get into some of the details about vasopressors and fluids and what may make the most amount of sense in the U.S. as well as in more resource-limited settings. So the first part is really about definition. So I'd like to start with a case here. So this question number one is a gentleman who's 45 years old who's presenting with fever, cough, and dyspnea for 3 days. Temperature is elevated at 40 degrees, blood pressure is 110/70, heart rate of 100, respiratory rate is 26. Patient appears acutely ill and lethargic. He has rales at the right lung base. Urine output is low at 5 mL per hour. Laboratory exam reveals a white blood cell count of 15,000. Hemoglobin is 12.2. Platelet count is 180,000. Electrolytes shows sodium of 138, potassium 4.9, chloride 105, bicarbonate 18, creatinine of 2.0, and they measure lactate of 6 milliequivalents per liter. Urine analysis is unremarkable. Various cultures of blood, urine, and sputum are sent, but the results are pending. And then the chest X-ray shows a right-sided lower lobe infiltrate. So this patient has, at this point, A, bacteremia, B, sepsis but not systemic inflammatory response syndrome or SIRS, C, SIRS but not sepsis, and D, both SIRS and sepsis, and finally E, neither SIRS nor sepsis. Maybe I'll give people about 15 seconds or so to select their answer in their mind. I'm assuming there's no audience response system here.
We actually do. We can, if you all will look at the emoticons there.
Okay.
Let's see. Let me hold on just 1 second. I cannot. Dr. Lee, I cannot remember how to do that. I haven't done it in a while.
Well, it's not absolutely essential, so I can just move on if you like, or.
Yeah, just they're going to submit their answers after.
Okay, that's fine.
So
okay,
that's fine.
Okay,
but
so
we'll do that.
Sure. So what I'll do is maybe after each question, I'll pause for a brief time so that so people have the opportunity to at least select an answer in their mind. Okay.
Okay.
So I'd like to now review some of these definitions. I suspect that these are maybe old for some of you, but I want to make sure everybody's on the same page. So the first term to be aware of here is a term called systemic inflammatory response syndrome, or SIRS. And as people probably know, this is an operational definition where you're expected to have a response to some kind of an insult that happens to the patient's body, and that response is that of inflammation. And so we define inflammation operationally by the body's response to that, and it will usually be manifested by these features, which include tachycardia, heart rate greater than 90, a derangement in temperature, either high or low, so higher than 38 or less than 36, and then tachypnea, so that the respiratory rate is more than 20 per minute, or some evidence of hyperventilation, so that the PCO2 is 32 or less. And finally, leukocytosis, leukopenia, or more than 10% bandemia. So the idea here is that, of course, the patient has been injured, and then the body is responding with inflammation. Since we can't really measure inflammation easily, clinically, we look for these simpler signs. So 2 or more of these 4 features would qualify someone to have systemic inflammatory response syndrome, or SIRS. The insult may be infectious, which is probably more common, for example, pneumonia, but the insult may also be non-infectious, like trauma, pancreatitis, burns, and so forth. Then the term sepsis is basically a subset of patients with SIRS, but the etiology of the inflammation is an infection. So it's basically somebody who is infected, and then they have 2 or more of the SIRS criteria. So we just went over SIRS, we went over sepsis, but an important distinction that may be helpful to some is that things like hypotension, bacteremia, lactic acidosis, organ failure, these are not actually required for someone to have sepsis or SIRS. So those are additional complications and a further subset of those with SIRS or sepsis. So if you go back to this question, I highlighted in red features that this patient has which qualifies him to have SIRS. So in this case, he has the fever, the tachycardia, tachypnea, and leukocytosis highlighted in red. And then in green, he has features that suggest that he is infected. That is the cough, the dyspnea, the rales at the right lung base, and then a chest X-ray which shows a right lower lobe infiltrate. And those are features, of course, that suggest that he has a pneumonia. So since he is infected and has features of SIRS, he would have sepsis. So the correct answer here is D, that he has both SIRS and sepsis. So moving on, this is the exact same patient and the exact same set of conditions, but now to explore a few more terms, at this point, the patient also has A, multi-system organ failure, B, septic shock, C, ARDS and severe sepsis, D, ARDS and septic shock, or finally E, severe sepsis. So once again, I'll give everybody about 15 seconds or so to gather their answers. Okay, so the definition of multi-system organ failure is simply somebody who has 2 or more organs that are failing. So examples include cardiovascular failure, respiratory failure, hemostatic failure, renal failure, hepatic failure, but it's not necessarily limited just to those organs. And then septic shock is a subset of patients who are in sepsis, but they are hypotensive despite IV fluids, so generally speaking, they would require vasopressor support. And then the modified Berlin definition of ARDS is as follows. You have to have all 3 of these features, and feature number 1 is an acute onset of bilateral pulmonary infiltrates, acute being within the last week or so. Number 2 is hypoxia, as defined by the ratio of the PaO2 to FiO2. And then finally, number 3, the cause of these infiltrates and hypoxemia cannot be fully explained by CHF. So as you know, heart failure causes bilateral infiltrates as well as hypoxemia. So it's basically a non-cardiogenic pulmonary edema that would qualify someone to have ARDS. Severe sepsis is probably the most important terminology to have clear in people's mind. And the reason is, generally speaking, somebody who's in septic shock, most people don't miss the fact that they're critically ill because they're hypotensive, and often they will require vasopressors and resuscitation. But the one that often escapes people's attention is the broader term severe sepsis, which can include patients with shock, as number one would suggest, but it can also include people who are not necessarily in shock, but they have either hypoperfusion or organ dysfunction. So, for example, some features that might suggest that a patient is experiencing hyperperfusion include poor mental status, oliguria, and lactic acidosis. And then, of course, you could have the organ dysfunction of any of the major organs in the body. And you only need one of these three features to qualify for severe sepsis. So these are all fairly arbitrary definitions. Like, for example, the heart rate cutoff of 90, it could have been 100, it could have been 120. So these are fairly arbitrary cutoffs. It's not meant to be used totally rigidly. However, it's still a very useful concept because, as this large study by Rangelfrosto suggests, that it is highly correlated with your risk of death. So if you take a large number of patients in the ICU in this study, if the patient had features that did not qualify them to have SIRS, their observed mortality in the ICU was only 3%. But if you met two of the four SIRS criteria that we discussed, mortality increases to 7%. If you have three of the four criteria, it goes to 10%. If you have all four of the SIRS criteria, it goes up to 17%. And patients with sepsis, that is infection plus two of these criteria, mortality is 16%, severe sepsis is 20%, and septic shock is 46%. One of the ideas that is suggested by this kind of a study is that maybe it would be helpful to identify patients early in their course, because by the time they clearly need the ICU care, i.e. septic shock, their mortality is almost 50%. So at least the recent emphasis has been to try to identify patients earlier on, especially at the severe sepsis stage, so that patients can be identified and treated earlier with a goal that they may have improved survival. This is the famous Roger Bone diagram, and Dr. Bone and his colleagues have really defined a lot of these terminologies. And so if you look at the large circle to your left, that is the universe of people who are infected at this time. And then the large circle to the right in green, that's the universe of people who meet the definition of SIRS, that is two or more of the criteria that we discussed. Then in the intersecting lens-shaped area in the middle, that's the Venn diagram that shares both infection and SIRS. So of course, then this is the subgroup of patients with sepsis. But among those with sepsis, there's a smaller subset represented by this small circle who are either experiencing shock, organ failure, or hypoperfusion. So these people then have severe sepsis. Patients with septic shock would be a smaller circle within the larger circle of people who with severe sepsis. And then the other feature of this is to recognize that infection is probably the most common cause of SIRS, but there are a number of non-infectious causes, examples being burns, trauma, pancreatitis, etc. And within that subgroup, you could have also severe SIRS, that is, you have hypotensive shock or organ failure and hypoperfusion from pancreatitis, for example. But since it's not due to an infection, you wouldn't really have severe sepsis, but you would have severe SIRS. So going back to our question then, as I highlighted before, the features in red qualifies this patient to meet the definition of SIRS. The features in green qualifies this patient to have to meet the definition of sepsis. And then this person in black has features of oliguria, and then lactic acidosis and metabolic acidosis, which qualifies him to have severe sepsis. So he's not quite in shock because his blood pressure is actually adequate, 110/70, but he has signs of hypoperfusion, so therefore he would meet the definition of severe sepsis. So moving on, with those terminologies clear in our minds, let's go and review the most recent international guidelines for the Surviving Sepsis campaign. And this guideline was put together in 2012 and then published in 2013. So I'd like to just highlight some of the key features that would be helpful to the clinician here. So question number 3 is, while you're evaluating this patient, the heart rate increases to 140 and the blood pressure decreases to 85/40. So which of the following interventions will likely improve this patient's survival? A, aggressive fluid resuscitation until CVP is 18 millimeters of mercury or higher. B, early administration of appropriate antibiotic therapy. C, pulmonary artery catheterization to guide fluid resuscitation and vasopressor titration in the setting of hypotensive shock and olivary renal failure. D, corticosteroids, and you may choose more than one answer if you would like. So again, I'll give you about 15 seconds or so to select your answer. Okay, so as I mentioned, the Surviving Sepsis guideline was put together in 2012 and then put together in 2013. It's a pretty long document, and they have 17 grade 1 recommendations for initial care of patients in sepsis. But rather than describe all 17 separately, what I'm doing here is I'm just summarizing sort of the 3 main features that essentially describe all 17 recommendations. So these recommendations can be broken down into 3 major goals. One is the goal of immediate resuscitation, and number 2 is administration of early antibiotics, and number 3 is source control, that is to figure out why the patient is sick, what the cause of the infection and the severe sepsis is. So the idea for immediate resuscitation is that if somebody is hypotensive and or having lactic acidosis, then the patient is likely in severe sepsis or septic shock, and so that the resuscitation should be started immediately and not wait until they get to an intensive care unit. And this is probably a very important point, especially in resource-limited settings where you might not even have an ICU, but immediate resuscitation can be begun as soon as possible wherever you are, even in the field. The Surviving Sepsis guideline actually is fairly explicit in terms of what they consider to be early goal-directed therapy, and so we'll talk about this as more studies have been published since that time. But the recommendations are to not just simply give 1 liter of fluid or 5 liters of fluid, but really to give resuscitation so that the physiologic parameters are normalized. For example, having a mean arterial pressure greater than 65, having adequate urine output defined as at least 0.5 mL per kilogram per hour, and a central venous pressure more than 8, and a venous saturation of 70% or greater. So the idea is that if someone is normotensive, making urine, has adequate CVP and adequate SVC saturation, then most likely this patient is well resuscitated. And the idea behind early antibiotics, of course, is that you want to treat the source of the infection as quickly as possible by giving appropriate antibiotics. And the general recommendation is to do so within 1 hour of the patient presenting to you in shock. And then source control is to not only give antibiotics, but to either get rid of dead tissue or to drain the pus so the patient is no longer experiencing the source of the sepsis to begin with. So one comment about lactate. This is universally available in most developed countries, but not necessarily in sub-Saharan Africa, for example. But it is a very important laboratory tests. And so one reason why you might want to pay attention to this is actually given by this study that was from 1970. So as you can see on the x-axis, this is the patient's blood lactate levels, but on the y-axis is the patient's survival. And I think the graph really says it very nicely, which is higher the lactate, more likely you're going to die. So it is a major thing to pay attention to. And this is one of the reasons why you want to target people who have severe sepsis, even if they're not necessarily in shock, because elevated lactate means that they have a high risk of death. In terms of this idea of early resuscitation, one side note that might be helpful for people is this concept of Landry hypothesis. And this hypothesis is illustrated nicely in this animal model. So this is a model of rats who are in hemorrhagic shock. So these rats are actually bled intentionally for 30 minutes so that they go into hemorrhagic shock, and then they study what happens to the rats with different speeds of resuscitation. So for example, some rats are immediately resuscitated, others are intentionally delayed for up to 60 minutes to see what the effect the speed of resuscitation has on these rats. So as you might expect, the lactate levels rise more dramatically and stay elevated if you don't resuscitate, and that's the very top line of the lactate graph. But the graph right below that in light blue is the one that you waited 60 minutes, and then one at the very bottom in dark blue is when the rats were immediately resuscitated. So this makes sense that if you delay resuscitation, you of course prolong hypoperfusion, so you get more lactic acidosis. Perhaps more relevant to us is the inflammatory markers. When they looked at interleukin-6 levels, you saw a very similar pattern where basically by not resuscitating or delaying resuscitation, you got more systemic inflammation as measured by interleukin-6 levels. If you look at what happens to the lungs, here's a histologic section. So these rats were sacrificed, and then they examined their lung sections. And notice that on this first one where it's unresuscitated, there is minimal edema here. But from the second slide, which shows immediate resuscitation and then delays of 30 minutes next to that, and then delay of 45 minutes and then delay of 60 minutes, you see progressive amounts of inflammation. You see lots of neutrophils and inflammatory cells when it's delayed 60 minutes, but you also see increasing amounts of edema, as you can see from the graphs at the bottom of the slide. So what this suggests is that if you delay resuscitation, then you're going to actually augment systemic inflammation, including the lungs. And so the more you delay resuscitation, the sicker the patient will be, and they will have more inflammation. So therefore, they are more likely to experience a critical illness, organ failure, and possibly death as well. So this is a very broad concept, but this is really the underlying principle that has driven the care of patients with severe sepsis for the last maybe 15 years or so. And so the obvious implication of the Landry hypothesis, of course, is that when we're treating a patient with severe sepsis, we should begin resuscitation as early as possible and be aggressive. So in some ways, this pretty famous paper by Manny Rivers, which was published in 2001, is really a test of the Landry hypothesis, except now done in humans instead of in rats. And so as I'm sure many people are already aware, this is a highly celebrated study that was done in Detroit, where they took 263 severe sepsis patients who met the SIRS criteria that we had discussed, and they were either hypotensive or had elevated lactates of 4 milliequivalents per liter or more. And what they did here was they compared standard therapy versus what they called early goal-directed therapy. And most of the goals were similar, that is, in standard therapy and early goal-directed therapy, the goal was to keep a CVP that was not low, mean arterial pressure that was not low, and a urine output that was not low. But for the early goal-directed therapy, they had one additional goal, which was to keep the SVC saturation more than 70%. And in keeping with Landry hypothesis, the goal was to try to reach these parameters within the first 6 hours of their presentation. And if you compare the standard therapy versus early goal-directed therapy, as you can see from the data, basically more things were done in the early goal-directed therapy in order to try to meet these goals within the first 6 hours. So, for example, there was more blood given, more fluids were given, and then the dobutamine was more often administered in the early goal-directed therapy. So, not surprisingly, then, with this, patients were more often likely to meet these goals if the CBP urine output and MAP. So, for example, with standard care, 86% of patients met all three of those goals within 6 hours, but in the early goal-directed therapy, it increased to 99%. So almost everybody was able to meet all three of those goals. Then, as Landry hypothesis may predict, the mortality in the hospital was significantly reduced from 46% down to 30%. And this is really the key or the seminal article that has radically shifted our management style of patients with sepsis for the past 15 years or so. The second component of the Surviving Sepsis campaign is to use early antibiotics, and there's really no good human randomized control study on this, mainly because it would be unethical to not give antibiotics early. But we do have some really compelling information from this retrospective human study. So here's a study by Kumar, which took 2,700 adult patients who were in septic shock, and as you can see from the graph, for every hour in delay of appropriate antibiotics, you saw an increase in the risk of death, so that each hour of delay was correlated with an increase of 8% in the risk of death. So it is very important to not only order the antibiotics early, but to also ensure with your nursing staff and other caregivers that the antibiotics are actually administered and patients do indeed receive the antibiotic as quickly as possible. And then thirdly is source identification and control. So here's an example of a 50-year-old man who presents with hypotensive shock and tender red left thigh. He denies cough, sputum, or abdominal pain. And as you can see, he is febrile, tachycardic, hypotensive. And the abdominal exam is unremarkable. The left thigh seems to be the source, as it is warm, red, and tender to palpation. Laboratory exam shows a elevated white count, but otherwise unremarkable labs, except for a lactate that is mildly elevated at 4. So patient is given vasopressors, intravenous fluids, and broad-spectrum antibiotics. So let's assume that early resuscitation is begun, and then appropriate antibiotics are given as quickly as possible. Here, we need to consider the source of the septic shock, and the most obvious source appears to be the thigh. But what's important here is that something like cellulitis or osteomyelitis, things like that, they don't typically cause severe sepsis or septic shock. It is not that it is impossible. They do occasionally cause septic shock, but usually cellulitis is a much more milder disease. So when you have somebody in septic shock with an infected leg, you have to think about a deeper infection, such as necrotizing fasciitis. So as a reminder, the most common sites of infection are, number one, the lungs. That's about half the patients with severe sepsis, followed by the urinary tract, and then the abdomen. So these three together probably explain about 90% of patients with severe sepsis. So this is a good starting point, is to look at the chest X-ray, look at patient's history about cough and sputum production, etc. Look at the UA, and then examine the belly very carefully. If you don't see any of those three sources, then it's worth looking at other causes. But you would not want to just settle on cellulitis as being the cause, because that is not a likely source of severe sepsis. So this patient ended up having necrotizing fasciitis and required an operative intervention by the surgical service. So the common sources of septic shock is on top here, and I've also added central venous catheters for places where these are used commonly. But the uncommon sources, so don't necessarily be fooled by these. They include cellulitis, osteomyelitis, decubiti ulcers, and then also pneumocystis carinii. And then the sources that cause severe sepsis but need further control in addition to routine antibiotics. You have to think about pneumonic effusions, which might require chest tube drainage, and then necrotizing fasciitis, as in our clinical example. Any abscess, of course, may need to be drained, and then perforated viscus, and then infected catheters and devices may need to be removed. So make sure you are thinking thoroughly about the actual source and then controlling the source to the extent possible. Just a brief word about pulmonary artery catheters. I think these are being performed less and less commonly, largely because multiple trials have looked at the utility of these catheters. And here's just an example of the 5 largest ones done in various parts of the world and for all different kinds of patients who are critically ill. And the bottom line is there's been no demonstrated benefit in terms of survival and even in terms of morbidity. So these are generally not indicated for routine use, which is good news for the resource-limited areas. So, a comment about systemic steroids. I think most people are aware that there is 2 sets of studies. One are the early studies where they use high-dose steroids for a short duration. So one example of high dose is 30 milligrams per kilogram of solumedrol. That's a huge dose, but it was only given for 4 doses or for 24 hours. And these kind of studies showed no benefit in terms of survival and only hinted at actually side effects like hyperglycemia. More recent studies have focused on a much lower dose, like hydrocortisone, 50 milligrams every 6 hours, and for a longer duration. In this study, for up to 11 days or so, and there is several studies that have looked at this, but the most recent and probably the better in terms of quality is the Cortica studies, which was published in 2008, and this is a randomized controlled trial of about 500 patients with new septic shock, and they compared hydrocortisone versus placebo, and there was unfortunately no improvement in survival. What it does show, however, is that you may need vasopressors for a shorter duration if you give hydrocortisone, and similar findings have been reported in several other trials. So this is a bit of an interpretation issue, where I think some people do use hydrocortisone on a regular basis because maybe you don't need to stay on your norepinephrine or on dopamine as long of a period, but a lot of people have stopped using this routinely because there's no mortality benefit. So going back to our patient, the most appropriate answer is to give antibiotics as early as possible. I'd like to comment now on some of the recent trials that will now modify the international guidelines that I just went over. Again, study number 1 is a study by Manny Rivers that I already explained in some detail, and this is the basis for the Surviving Sepsis campaign and the current international guidelines. Now, the problem with this is that this is a study that was done in 2001, and it really hasn't been replicated until relatively recently. And so there has been some criticism of this study, which we will explain in a minute. But one of the major papers that have maybe started to shift our thinking a little bit is a study by Maitland, and this study is called the FEAST trial, which was published in 2011. This study is also controversial because the findings were so dramatically different from what was expected. But this is a study done in Africa with African children. The average age was 24 months, and they focused on kids who had severe febrile illnesses and they had impaired perfusion, evidenced by either respiratory failure or altered mental status. But this study did not really include patients who were in severe hypotensive shock. So that subgroup with severe hypotensive shock was not really part of the study. And since this is Africa, there's a large number of patients who had malaria. About 4% of them had HIV. And here they were comparing three kinds of fluids. One is normal saline bolus, the other is albumin bolus, and third is no bolus at all. It's interesting to note that the study was controversial even at its inception because there were many who felt that the study was unethical because everybody at this point has already accepted the Manny Rivers paper, which suggests that we should be bolusing people. But I think on the grounds that these were kids and also that even these boluses may not necessarily be benign in Africa, this study was eventually allowed to proceed. So, for example, in the U.S., if you over-bolus somebody and they develop, let's say, pulmonary edema and then respiratory failure, you may be able to fix them relatively easily with maybe some Lasix and then maybe BiPAP or even intubation if necessary. But in Africa, where we don't necessarily have access to those kind of resources, and there may not be an ICU, overhydration is not necessarily a benign side effect, and so the study was thought to be justified. So this is a study that's basically comparing two different kinds of boluses, that is normal saline versus albumin, and that is compared to no bolus at all. So what happened here, though, was very counterintuitive and actually different from what was expected, which was the mortality at 48 hours as well as at 4 weeks was actually the lowest when there was no fluid bolus given. So this, of course, in many ways kind of contradicts the findings that we've been talking about as well as the international guidelines. So it wasn't clear what to do with this study. People did look at people or the patients with and without malaria because some people worry that maybe those with malaria who have cerebral malaria, they may have cerebral edema, and then fluid resuscitation may actually increase complications. But that did not seem to explain why the mortality increased. So they looked at patients with and without coma, and then also people with a hemoglobin less than 5, with and without lactate elevation. But none of those kind of subsets truly explain why patients with either normal saline bolus or albumin bolus had an increase in mortality. So, at least in my experience, many people try to explain this away. One was, well, these were patients from sub-Saharan Africa. So for those of us who are not in sub-Saharan Africa, maybe this study is not relevant. For those of us who are adult doctors, say, well, this is a pediatric population, so maybe this study does not apply to us. And then finally, some people have said, well, they excluded patients who are in severe shock, so maybe those in severe shock still need the fluid boluses. So again, it's not clear what the right answer is, but it did create a lot of discussion, and you may already have your own thoughts about it, but it was clearly controversial. Most recently, this study just got published on May 1, and this is a study called the PROCESS trial, and this is a randomized controlled trial of about 1,300 patients with severe sepsis. Again, they had to be hypotensive or had elevated lactate. And they compared 3 different treatment approaches. One treatment approach is the classic Manny Rivers approach of early goal-directed therapy, where you try to normalize the MAP and the CBP and the SVC saturation. They also try to maintain a hematocrit of more than 30%, and if it was less than that, they gave blood. And then they compare that to what they call standard protocol, and so this protocol did not require the use of a central line, for example, but instead looked at the systolic blood pressure of 100 or greater as the goal, and they also used something called a shock index, which is the ratio of the heart rate over the systolic blood pressure, and they try to keep that ratio to less than 0.8. And finally, they compared these two protocolized approaches to what they considered usual care, and this is usual care at U.S. academic medical centers between the years of 2008 to 2013. So they had approximately 450 people in each arm of the study, and then, as you can see, IV fluids tended to be more aggressive at the two protocol arms. Blood was more often given with the early cold-directed therapy. Vasopressors were a little bit more likely to be used with the protocolized care, and then dobutamine was more likely to be used with early cold-directed care. With these differences, what they found was that the blood pressure was better with the protocolized care, so that 83 to 84% of patients had a MAP greater than 65 with the protocolized care. But what we, of course, want to see was a lower mortality, as demonstrated in the Manny Rivers paper from about 15 years ago or so. But unfortunately, the 60-day mortality was not different statistically. So does this mean that the Manny Rivers paper was actually wrong and that there is no significant advantage of this early resuscitation? Or some people have argued that the usual care has already shifted toward early resuscitation as a result of the international surviving sepsis guidelines. So the usual care already incorporates early resuscitation, which is why it wasn't necessarily better to do further protocolized care. So again, you will have to be the judge as to which is the correct answer. But at this point, it's not clear whether the early cold-directed therapy as done by Manny Rivers needs to be explicitly applied as he had originally done. So here's a summary of the three major papers that I mentioned: the Manny Rivers paper, the FEAST trial in Africa, and then the most recent process trial. In terms of quality, they were all reasonable quality in terms of the method of allocation, although the process trial used central allocation, which is sort of the gold standard in terms of the quality of randomized controlled data. And then, again, to point out that the FEAST trial was among African children. The other two papers was among U.S. adults. In terms of other markers of quality, Manny Rivers' paper, their outcome and their methodology was not registered because this was well before the requirement for registering randomized controlled trials. It was certainly the smallest of the three trials, and this is a single-center trial as opposed to the FEAST trial and the process trial, which are multi-center trials. And in general, multi-center trials are thought to be much higher quality and affected less by bias. And then finally, Manny Rivers' paper had a pretty strong profit motive, as many of the authors and investigators had ties to industry, but the FEAST trial and the process trials were free from that kind of influence. So overall, I think the FEAST trial and the process trials are larger, multi-center, and higher quality randomized controlled trials compared to the Manny Rivers paper. So you might want to put some more emphasis on the latter two trials rather than the Manny Rivers trial, but it's still up to you to decide which study to believe. And if you follow the Manny Rivers approach, you would be asked to normalize the MAP, normalize the urine output, normalize the CVP, and normalize the SVC-SAT, which would require the use of a central venous catheter and an arterial line. If you believe the FEAST trial, you might say, well, we should probably resuscitate aggressively, but please be careful in children, be careful in Africa, and be careful if your patient does not have severe hypotensive shock. With the publication of the process trial, maybe this recommendation needs to be modified further, which is maybe we should continue to resuscitate aggressively, but normalizing CVP and then normalizing the SVC-SAT doesn't seem to have any additional advantages. So maybe we should just focus on an acceptable blood pressure, like a MAP goal of 65, and then to normalize a urine output. But the other, I think, a broader caution here is be careful about trusting the results of one randomized controlled trial, especially if it is not the highest quality in terms of the size of the patients, the single-centeredness of the study, or having some biases like the profit motive and so forth. So personally, what I would do is to modify the international guidelines to follow the goals of immediate resuscitation, early antibiotics, and source control, except I would strike out the requirement for CVP and the SVC SAT, but still try to aim for signs of adequate perfusion by the blood pressure and urine output as soon as possible. But overall, I would say I think this is good news for resource-limited settings because you don't have to feel bad if you're not routinely using things like arterial catheters and central venous lines and so forth. The last part of this talk is going to maybe explore some of the details about vasopressors and the fluids. And again, I would say that overall the news is pretty good for taking care of patients in resource-limited settings. So here's question number 4. So while you are evaluating the patient, heart rate increases to 140 and blood pressure is 85/40. So which of the following vasopressor will likely improve survival compared to other vasopressor options? A, vasopressin, B, norepinephrine, C, dopamine, or D, no one vasopressor is better than the other for improving survival. So again, I'll give you about 15 seconds to try to answer this. Okay, there's maybe 2 major papers that might be worthy of your attention. The first of this is a study by Russell in 2008. And actually, I should mention that there have been many studies comparing various vasopressors, but in general, there are poor quality and very small studies. So I would draw your attention to the 2 papers that I'm going to highlight here because these are the more recent trials that are much more rigorously designed. So this study by Russell included 779 patients who were already on norepinephrine for septic shock, and they compared the strategy of leaving them on norepinephrine or actually switching them to vasopressin. And what they looked at was the overall mortality as well as the risk of adverse events. The bottom line here is there was really no difference between norepinephrine versus vasopressin here, either in terms of mortality or in terms of adverse events. The other major study to note here is a study by DeBacker in 2010. This is a study of about 1,600 patients who were in hypotensive shock. And the cause of shock included sepsis, but also included other causes of hypotensive shock. And here they're comparing norepinephrine versus dopamine. What they found here was that, again, there was no significant difference in mortality at 28 days or at 6 months. However, the risk of arrhythmia, the most common of which was AFib, but did include some BT and BF, was about twice as likely on dopamine compared to those who were on norepinephrine. So the answer to this question is that no one vasopressor is better than the other for improving survival, but you may argue that maybe dopamine is more likely to cause side effects, especially in terms of arrhythmia. So the official surviving sepsis guidelines recommend the use of norepinephrine, but I can tell you at Kajabi Hospital in Kenya, we still tend to use dopamine because norepinephrine is significantly more expensive. The final question here is for this exact same patient with tachycardic and hypotensive, if available, which of the following fluids is preferred? A, albumin, B, normal saline, C, hetastarch, or D, they are all equal. So again, I'll give you about 15 seconds to select your answer. Okay, so there are actually many papers, and there have even been some more recent ones that's actually not included on this slide set. but I'll just highlight some of them, which I think really shows the exact same result no matter which study that you focus on. So the first study here is called the SAFE study. Way back in 2004, this was a randomized controlled trial of almost 7,000 ICU patients who were in need of resuscitation, and they compared saline versus 4% albumin. And the bottom line was there was really no difference in mortality with albumin. And so some people have used this data to say, well, it is safe to use albumin because there was no increase in mortality as was suspected by some of the observational papers from a few years earlier. But other people have simply pointed out that albumin is obviously more expensive and certainly more expensive in resource-limited settings. So why use something that is no better if something like saline is available and is just as good in terms of mortality? And that's the bias that I would also have as well. But it is also important to note that some of these colloid medicines are actually harmful. And so here's a paper by Turner, which did a randomized trial of about 800 severe sepsis patients. And here they compared heterostarch versus lactated ringers. And actually the mortality and the need for renal replacement therapy, that is dialysis or CVHD, was significantly higher with heterostarch. So things like heterostarch and also pentastarch have shown similar findings that either it increases mortality or increases the risk of renal failure. So at least the colloids of that subclass should probably be avoided. The most recent paper that have examined this is called the ALBIOS trial, which was just published this year in 2014. It's a randomized trial of about 1,800 patients with severe sepsis, and they compared albumin infusion so that their serum albumin levels were at least 3 or higher, and it was compared to the more conventional crystalloid fluids. And the bottom line here is that there was, again, no significant difference in mortality. So the answer to question number 5 is that all the fluids are basically equal, although you might note that heterostarch and pentastarch are actually harmful, so you should probably avoid that. So in summary, the 2012 Surviving Sepsis Guideline strongly recommends that we use crystalloids, either because the colloids are either harmful in the case of heterostarch and pentastarch, but in the case of albumin, it doesn't really offer any significant advantages, but it is much more costly. So the recommendation will be to try to use albumin, is to actually use normal saline or lactated ringers instead. Okay, so I believe that's my final slide. So I don't know if there are people who are still in the audience who have any questions.
Anybody have any questions for Dr. Lee? Dr. Lee, I was just, and if you do, please you see the emoticons there, and you can just the hand there, you can just activate that, and I'll call on you if you have a question. I was curious, in Kajabi, do you all use central venous catheters frequently, or for your sepsis patients?
Sure. We don't use it frequently. So all our central venous catheters are donated, and they cost anywhere from $30 to $70 US. So it is still very expensive for our population, which makes on the average about $2 a day or so. So we try not to use it unless absolutely necessary. So we put it probably maybe once every month or two, so maybe 5 or 6 times a year it would be my guess. And it's generally done because we have no other way of giving them vasopressors. We try to just use dilute dopamine through the antecubital vein if we can get away with it. But every once in a while, we can't establish any other form of IV access, and so we do put in central lines, but it's pretty unusual.
Yeah, that was my next question is, could you just make a brief comment or two about the use of pressors with peripheral sites?
Yeah, so I have to say that in the U.S., I've not used vasopressors through anything other than a central line of some type for any prolonged period of time. So if we start something peripherally, we generally put in a central line in the U.S. And of course, part of it is that we worry about things like limb ischemia and things like that. But in Kenya, because of cost considerations and also lack of availability of the catheter itself, we use the antecubital vein, as I mentioned earlier. So far, in my approximately 3 years of working in Kenya, I've not seen a single case of limb ischemia due to the vasopressor. But like I said, we do use a larger peripheral vein like the antecubital space, and then we use dopamine that's been diluted. So that may be part of it, or maybe our concern about limb ischemia was exaggerated. I'm not sure which.
Yeah, I've actually seen peripheral lines used a number of times, and that's it makes sense theoretically that would be the concern, but I've seen it done a number of times, like especially like in someone that arrives before they have central line access, and we initiate pressors out of necessity, peripherally, and they have always done fine. I've never seen a problem. But,
yeah, and that's been my experience as well.
Yeah. Anybody else with questions, please feel free to ask any questions for Dr. Lee. Well, it seems like we have a shy audience here, or either they know everything. No. That was a phenomenal presentation. I really appreciate it. I guess I was going to, maybe I'm oversimplifying it, your kind of summary statement about the goal-directed therapy, the early goal-directed therapy. It seems like, I guess in summary, maybe we should be, aggressively hydrating these patients, but not too aggressively hydrating these patients. Is that sort of the take-home message?
Yeah, I think that's a fair, quick summary. Now, as to what that means, what is aggressive and then what is not overly aggressive, that's a bit subjective. But I think a summary of these major studies really suggests that we do need to be cautious about overhydration as well.
Yes, sir. Yes. So, okay. Well, very good. If there's no other questions, again, Dr. Lee, thank you so much for just a phenomenal presentation.